Hi, this is Matthew Cheng. I'm one of the infectious diseases doctors and medical microbiologists at the MUHC. I'm also on the trial steering committee for Canada's nationally funded treatment trial for COVID-19. First of all, I'd like to thank you very much for your time and your expertise. We sincerely appreciate it and can benefit from your past experiences. I'd like to follow up on one specific question about the benefit of treatment, particularly in patients who have severe or critical illness. My question to you would be if you think we should treat all patients, regardless of severity, including those with very minor disease. My second, maybe we'll just start with that. That'll be my first question for now.
I will give my opinion first. In my opinion, for the mild cases, we actually to provide quarantine services for them. It's for the epidemic control rather than treatment. But for the severe cases, it's definitely we need to provide comprehensive supportive care for them as early as possible.
My opinion is I don't think the antivirus therapy is very effective in the critically ill patient, because we need extremely strong life support. You know, if the patient get a septic shock, get hypoxia, a lot of things could affect the final result of the clinical trial of the antivirus therapy in this kind of critical ill patient. But in my patient, I think we need a very well-designed, controlled, double-blind study.
Thank you. That's very helpful. On that note, were you able to pick up on any early markers to predict patients who would become very sick, very critically ill, and would require that extraordinary supportive care?
Yeah. Okay, I can answer this question first. Because I'm a cardiology doctor, there's a lot of cardiovascular complications in this patient. I have investigated about 77 patients and trying to find out some biomarkers. Interestingly, and we do have some. We can get from the lessons of the previous ICU experience that, like high sensitivity cardiac troponin maybe is one of the important biomarker of the all-cause death and the cardiovascular death. There is some difference, but we need further investigation. Is like thrombocytopenia, lymphocytopenia, elongation of the PT, and elevation of the dimer, maybe, but I didn't do that. Finish the statistic analysis yet. I think.
May I ask a question from here?
Yeah.
It's Peter Goldberg. May I ask a question?
Yep.
Please go ahead. Yes. Why did the patients die? What did they die from?
Most of the patients die from respiratory failure, and to our surprise, most of these patients have hypoxemia, and also their carbon oxygen concentration is relatively high. Maybe the highest of our patient is over 100, and we think for this patient, the lung lesions of this patient maybe most of them are interstitial changes, and the ventilation was affected for this patient, and you can't control these hypoxemia or high hypocalcemia. So this patient suffered from respiratory failure for most of these patients.
I think three most important cause of death is septic shock, and respiratory failure, and cardiovascular complications. Top three.
Yes. Okay. Dr. Peter Goldberg, are you with us?
Yeah, yeah.
All right,
Do you
great.
hear me now?
Okay. We were offline for a couple of seconds, and okay, please continue
Okay.
with your dialogue.
When the patients who survived, how long was the usual duration of mechanical ventilation?
It's
10 to 14 days.
I think from the onset of the symptom to intubation, it's about 2 weeks. The mean duration is 2 weeks. From intubation to discharge or to stop ventilation is usually 10 days to 2 weeks.
Okay. Okay. And my last question is, how often, or what was the prevalence of the myocarditis? We're getting some reports from some case in Seattle of a patient getting better, and then he had myocardial failure, cardiac shock, cardiogenic shock. Is that been a problem either early or later in your patients?
That's my question. Okay. So we analyzed all dead patients, and I retrospectively investigated their data. We do have 3 patients with cardiac shock, but it's not at the beginning of the disease, but it's at the end of the life. And before that, the echocardiography of these 3 patients is fine. In 2 patients, and another patient had previous myocardial infarction. So, in my opinion, there's no evidence of the viral myocarditis in COVID-19. No evidence.
Okay.